So good morning. Today we'll be giving the neuropathology conference for the month of November. Special thanks to Dr. Gultike and Dr. Sayed for helping with this lecture. Really appreciate your time. So let's get started. Okay, so first case. So a 39-year-old female with past medical history of multiple sclerosis and a quote-unquote brain lesion that has been known to be present since 2006, where apparently it's growing. She's presenting now with progressive headaches and bilateral upper extremity numbness and tingling. So first case, let's do Mike Silva. You there?
Yep, I'm here.
Okay. So what are other things you might want to know about this case? So young female, MS, known brain lesion, now progressive headaches and upper extremity numbness and tingling.
So I would ask about like the status of her MS, like if she's treated, like is she like relapsing, remitting course?
Exactly. So I think that's very important, right? She's presenting with some like upper extremity symptoms. You want to know if that's been old with her history of MS. That might explain those symptoms. That's good. While other things maybe related to her headaches or something like that.
I would ask about the quality of the headaches, if they're positional, like how she describes them.
Exactly. How about her upper extremity numbness and tingling? You want to know something more specific about that?
Yeah, I would ask about like the distribution of it, if it's in a particular distribution, or it's kind of vague.
Exactly. Perfect. So one thing also you want to know, if a female, it's like young female with headaches, you started thinking about maybe serotumor, all those things. You want to know if she had any ophthalmologic exam. Obviously she didn't have, but a rule-out papillogram is always helpful. You already mentioned about asking about the symptoms, if they're related to her MS, and about any dermatomal distribution to rule out spine pathology. Very good. Excellent. Okay, so this is her physical exam. Her physical exam, it's basically normal, full strength, no pathologic reflexes. So what kind of images do you want for her?
MRI, brain, and C-spine.
Okay, very good. So this is the first set of images.
So on the first image is on the sagittal, it looks like she's got a little bit of tonsillar descent. Can't really measure it, but it looks like it's pretty significant. No evidence of a syrinx on that image. And then axial T2, I guess, also shows evidence of that.
What do you think about this and this? Do you think this is what?
So she's, yeah, so it looks like there's a mass there, like the level of the foramen magnum, kind of mixed T2 hyperintense and isointense.
And this is with contrast.
And it is not enhancing.
Exactly. Perfect. Very good. So how would you describe this lesion? Non-enhancing lesion, the posterior aspect of the foramen magnum, as you mentioned, extends from the midline, from the inferior aspect of the fourth ventricle, going all the way to the upper cervical spine at the level C1. Very good. Now with those images, would you like any other additional imaging? If you have a posterior lesion, a posterior fossa lesion, will you want any other imaging?
Not sure. I mean, I guess you could get a CT, but
okay.
I don't know.
How about doing a neural axis imaging? Is that?
Yeah, I guess you could MRI the rest of the spine.
Looking for what?
Whether there are other lesions, drop mets, or anything else.
Exactly. Perfect. Anytime you're thinking about posterior fossa the lesions, you want to rule out any additional lesions in the spine, in the neural axis. Very good. Excellent. So now, young female, non-enhancing posterior fossa lesion. What's your differential?
Non-enhancing, I would think of maybe subependymoma,
Mm-hmm.
endymoma. You could get, epidermoid, but didn't really restrict.
Exactly.
She's a little old for like the more pediatric posterior fossa tumors, but I guess you could also consider those.
Exactly. Excellent.
Yeah.
Very good. So subependymoma, top of the list. Ependymoma, as you mentioned. Choroid plexus papilloma, you can throw it in there, although most of them in hands. Dermoid, so another important one, although those are T1 hyperintense. Epidermoid, as you mentioned, another like rare. I mean, it's not likely, but you can say medulloblastoma or exophytic glioma. Very good. Excellent. So how will you treat this patient?
It sounds like she's symptomatic from it, and
Mm-hmm.
it's fairly accessible. So could probably resect it, suboccipital approach, maybe with the C1 Lamy.
Excellent. So definitely resection, and obviously, as you mentioned, suboccipital with C1 laminectomy. Adjuvant treatment, I mean, depends on what is the pathology, but if you're suspecting supraependymoma, that's not needed. Excellent. Very good. Okay.
Right. Good morning, everyone. So this is the lowest magnification of the tumor. At low magnification, you can appreciate the presence of multiple nodules, and the tumor is not very cellular, and that's an important finding in this particular tumor. Next slide, please. So now we're zooming in on one of the individual nodules, and within each nodule, you can see clusters of tumor cells. And next slide, please. And here is the cytologic features of the tumor cells. First of all, the background, as you can appreciate, is very fibrillary, which tells us this is most likely a glial neoplasm. And the tumor cells are kind of similar in size and shape, which we call absence of atypia and pleomorphism. And the chromatin, if you look at the chromatin within the nucleus, is kind of salt and pepper. That's what this is a term that we use in pathology to tell us this is of, CNS tumor. Next slide. Back to low magnification, you can appreciate, in addition to the small nodules of tumor cells, we have dystrophic calcifications, which are in the center of the field. Dystrophic calcifications are historically associated with any slow-growing process, not necessarily neoplasm, although we most commonly see them in neoplastic processes, but can be associated with any other slow-growing process. Next slide. And this is Ki-67, which is very low, about 1 to 2% maximum. So this is an example of subependymoma with its characteristic histologic features, and subependymomas are WHO grade 1.
Perfect. Excellent. So supraependymomas represent about less than 1% of all CNS tumors. As he was mentioning, histologically, they're classified as low grade, WHO grade 1. They occur most frequently in the 5th or 6th decade of life. Most of the cases are asymptomatic, but if they have symptoms, they're mostly caused by either hydrocephalus, spontaneous tumor hemorrhage, or mass effect on nearby structures. The majority are located in the fourth ventricle, half of them. They're followed by the lateral ventricles, about 30 to 40% of them. And they usually do not enhance on MRI with contrast, but they can also enhance. As it's already mentioned in pathology, there's a cluster of isomorphic nuclei embedded in a dense, fine, and glial fibrillary background, and they can have microcystic formations. They're usually positive for GFAP, NSE, or NCAM, and it's important to remember that they're classified as ependymal tumors, which is different grades, and they're WHO grade 1, along with mixed papillary ependymomas. Okay, perfect. Oh, we have this study published at JNS looking at the clinical and radiological and pathologic features of a series of 43 patients with the subependymomas. Interesting in this paper is that about 80% of the subependymomas were radiologically diagnosed as other tumors. And here, as we all know, is that long-term outcome, the 10-year recurrence-free rate is about 90% in these tumors, and the survival rate in 10 years, it's obviously more than 90%. So very benign tumors. Yeah, but importantly, in this article, that you should always include subependymomas in the differential diagnosis, especially posterior fossa lesions. Okay, next case, a 50-year-old male with 1-year history of progressive low back pain with left lower extremity weakness. He also complains of persistent spasms in the left lower extremity, although he denies any upper extremity symptoms. Let's see, is Vignesh around? Or Eva?
Yeah, I'm here. Sorry, I was on mute.
Okay, so 50-year-old, 1-year history of low back pain, left lower extremity weakness, some persistent spasms in the lowers, worse on the left. Any other things you might want to know about the history?
I guess in terms of like, does he have sort of like symptoms of hyperreflexia, any clonus, any gait abnormalities like bowel bladder changes?
Exactly. So looking at myopathic symptoms, and obviously you always want to know about urinary bowel issues. They're prognostic factor for spinal cord tumors. That's very good. Also important to know if the patient had a history of back pain for 1 year, it's important to know if they had any prior imaging, so you can compare if there's any changes. Okay, very good. Physical exam, basically he has some slight weakness of the left hamstring, 4 of 5, and then some hyperreflexia of the left patellar reflex. What kind of images would you want to have if you have some hyperreflexia and some lower extremity weakness?
Yeah, for sure. I mean, I think you could start with like MRI of the either like lumbar spine or MRI thoracic spine, but more likely in the lumbar spine. Just given
Okay,
the isolated. Yeah.
So let's start with this.
So on the so it looks like he's got lesions in both the thoracic and the lumbar spine. The T2 sequences are on the left side. In the thoracic spine, he's got a it looks like an intradural extramedullary lesion. So in the so
this is the thoracic, and then this is the lumbar.
The lumbar. So they look like multiple intradural extramedullary lesions that are contrast enhancing, and also hyperintense on T2 sequence.
Exactly. Very good. So basically extensive, like you were mentioning, intradural extramedullary, T1 isointense, T2 hyperintense, enhancing lesions all throughout the spine. Obviously compressing the spinal cord here in the thoracic spine, as you mentioned. Very good. So any additional workup, you see this patient with progressive symptoms and a lot of lesions in the spine. Any other workup you want to know?
Yeah, for sure. I mean, in these sort of patients with multiple spine lesions, like you'd be concerned about one, like metastasis either from an extra CNS location or drop metastasis from somewhere in the, you could do an MRI of the brain and the cervical spine just to rule out any sort of additional lesions in the near axis.
Exactly, I agree with you. So obviously metastatic workup and a neural axis workup. Exactly, perfect. Okay. So what's your differential?
So with regards to intradural extramedullary lesions, you would be worried about something like meningioma, schwannoma. I guess less likely given how many there are, but like you could also, you'd consider like hemangioparasitoma, and then some sort of like leptomeningeal metastases, like small cell lung cancer, or something of that sort, just given how many lesions there are.
Okay. How about a particular tumor that usually happens on the lumbar, like conus?
I guess yeah. So in that location, like myxopapillary ependymoma would be a big one.
Very good. Okay. So you kind of mentioned them, but extensive lesions all throughout the spine is very hard. But myxopapillary ependymoma, it's one of them. They can spread. They have leptomeningeal spread, ependymoma, strocytoma, metastasis. Schwannomas and meningiomas, they're usually a little bit more localized, but obviously you can have them in the differential too. How do you treat this patient?
So his exam is actually pretty good given the like burden of disease he has. So I think, but he is symptomatic, and so I think he would benefit from, I think resection. It looks like the thoracic spine lesion is the one that is causing like a lot of his symptoms. So I think he would benefit from surgical resection, at least for the lesions that are causing spinal cord compression, followed by adjuvant radiation therapy.
Exactly. So I agree, definitely surgery, right? The patient is clearly symptomatic. And again, as you mentioned, the patient is having some myopathic symptoms, and it looks like the thoracic lesion is the larger one. So you agree that going after the thoracic lesion is better than trying to go after everything, right? Okay, very good. So basically that's what he had. He had a thoracic LAMI decompression. First, you want to decompress the spine to help relieve the symptoms, and then you want tissue diagnosis to see what other treatments the patient will benefit if he needs further surgery, radiation, chemotherapy. Excellent.
Okay, so this is the smear preparation that we do at the time of the frozen section. The reason we do smear because it gives us some features that are difficult to see on the actual frozen. For example, here, first of all, if you look at the cytologic features, again, salt and pepper, similar to the features that we saw in the previous case of the subependymoma. Also, in the background, you can see a little bit of fibrillary structures. Next slide, please. In addition to the fibrillary structures, we have these areas of what appear to be mucoid or myxoid material. Next slide. This is the actual histologic section. So here we have large pseudocystic spaces that are filled with substance that is similar to the one we saw on the smear, which is myxoid material. And there are some vague papillary formations. For example, this is a papillae in cross section. So this would be the core of the papillae, and these are the tumor cells that are palisading around the papillary structure. Next slide. This is a closer look again at the cytologic features. There is no atypia or pleomorphism, no high-grade features. By high-grade features, we mean no mitosis, necrosis, or vascular proliferation. Also, this is higher magnification of the myxoid material, and this is a very nice papillae, again in cross section. So this is one of the characteristic features of this tumor, is that the tumor cells are kind of palisading around the center of the papillae. Next slide. And the Ki-67 is again very low, 1 to 2% in maximum. So this is a case of myxopapillary ependymoma, WHO grade 1.
Excellent. Okay.
I was going to talk a little bit about the case. I don't know if Dr. Vanni is on the line, but first of all, congratulate Vignesh for his most mature differential diagnosis. That was very excellent. If you go back to the films, you'll see that it looks like something that's terrible. I mean, there's multiple lesions. It's all over the place. But myxopapillary ependymomas can look like that occasionally, and it's kind of controversial as to what to do with this guy, because he's pretty well neurologically intact, but he has severe cord compression. at multiple levels. And I don't know if you can appreciate it just based on these films, but I think the decision, and correct me if I'm wrong, was that he just had one of the lesions removed, one of the dorsal, somewhat compressive lesions, but the large, severely compressing ventral lesion was left alone.
Correct.
And
Correct.
Yeah, that's correct, Steve.
so Steve, tell me what the overall plan is.
So the plan for this gentleman, we decided, number one, to make a diagnosis, and I thought the least way we could hurt him was to take the most dorsal lateral lesion off. That the ventral lesions, I thought, going after them, I did show you this case. I showed this case to a lot of people, very perplexing for me. And that the parts that were involving the lumbar spine extended all the way out through the sacrum and into the sacral roots. I didn't know if they were causing him to be symptomatic. And again, yeah, this is a very functional guy, still is. So I made the decision to go after the thoracic lesion, the dorsal thoracic lesion, the most accessible, make a diagnosis, and then make a decision. And that's where we've left it from now. And he did well from that.
So you have your diagnosis, which is the diagnosis I suspected as well before surgery.
Correct. And then he actually went on to needing a VP shunt. There was some evidence of blood in his CSF. He developed communicating hydrocephalus, and he's been shunted. And at this time, we've been watching him carefully, and I gave the family and the father the option to go back and actually, yeah, I did show you this case, to go after the more ventral thoracic lesions. They're a little reluctant to consider surgery right now. He's actually back to work and very functional. So that's where we're standing.
Okay. No, I just think, it's a tough decision. I agree. I mean, almost certainly he will deteriorate from these lesions. That's severe compression. It's just a question of when, and it's always a tough decision, because if you go in late when they have significant neurological dysfunction, you can take out the tumors and they don't necessarily get better. On the other hand, if you do it early and you have a complication, you take them from a walker to a non-walker. But even though there are multiple tumors, the overall prognosis isn't like horrible. I mean, it's benign disease. It's not like he's going to get multiple occurrences, and that's a manifest on the Ki-67 being very low.
I'm sorry to interject. This is Rag. I mean, I think when a myxopapillary ependymoma presents like this, in spite of the benign looking histology and the low Ki-67, you can predict the course of this disease. This is going to progress, and you're going to have somebody who's going to be compromised, and you'll have a crisis on your hands. I think the hydrocephalus is completely predictable, and what you're going to see next is the appearance of multiple loculations within the subarachnoid space because of the scarring related to the tumor and the surgery. And you're going to be playing whack-a-mole with these lesions and those cysts. So I would encourage you to subtype this ependymoma in the hope that you find a targeted treatment that might be an option. There are molecular subtypes of ependymomas, and perhaps he'll be fortunate and have a targeted treatment available to him. Otherwise, he needs spinal radiation before you have a crisis on your hands.
So thank you.
I completely disagree. I mean, that's not going to be very radiation responsive. And I have patients, at least a couple of like these, who, it was like a 10 or 12 hour surgery, T12 to S2, but they're 10 or 12 years out without significant recurrence. So radiation pretty well makes you, anyone who wants to go back in and decompress the cord have a really tough time.
Alan, I can show you complete responses to radiation therapy for myxopapillary ependymomas that present with metastases, and I can show you the exact opposite clinical course. So I'm impressed to hear.
So radiation for a KI, something that's not dividing rapidly.
The rate is low, but look at the volume of this lesion, how little space there is in the canal. And
That's why I would say do surgery.
Yeah.
So these are the opinions I've gotten. I've shown this case to a lot of people, and I tend to agree that I think that those thoracic lesions, he needs to be decompressed. I have been following this guy carefully. I'm actually his son is a close friend of a very good friend of mine, and I told him, you know, if you're showing any change whatsoever, we need to remove this. And I've also discussed this case, and I've been told that we're probably better off if we do radiate the lesions in the lumbar spine, resect the lesions in the thoracic spine. I don't know what your thoughts are, John or Alan.
That's the whack-a-mole strategy.
Whack-a-mole. I mean, what do you whack-a-mole? I mean, you're thinking that they're just going to keep popping back up after you resect them?
Yes.
I don't. I'll show you two cases where the guy has been stable for 10 years and similar pathology.
Look at all the dorsal lesions you have there. And there's very good data that metastases, you can pluck one of these lesions out, and the data would suggest, this is very clear, at least in pediatrics, that the metastases don't always necessarily reflect the other lesions. So you pick out one lesion, there are multiple other lesions. You don't know what the Ki-67 is for those other lesions.
How old is this guy?
He's
Young.
51.
Yeah, maybe Peds is different. You know, I wouldn't say that that's what happens in adults.
Yeah.
So we've solved this issue, this problem. Thank you.
Please follow. I think it'll be a good experience for us all to hear what happens to this patient.
Okay, so myxopalliary ependymomas, real quick. Ependymomas, mostly of the conus and filum. They're WHO grade 1, but as we were discussing, this distinct entity because of the tendency to infiltrate rather than simply displace adjacent structures, usually present in the 2nd to 3rd decade of life with back pain and progressive neurological symptoms. There's a slight male predominance. It's associated with typically high leptomeningeal spread risk with further localizations along the neural axis. Surgery is the treatment of choice in some of the patients, and the goal is GTR, gross total resection, if possible. Real quick pathology, as we already talked about, differentiated cuboidal to elongated tumor cells, radially oriented around a vascularized myxoid course with a myxopapillary appearance. Usually there's no atypia with low mitotic activity, and they stain positive for GFAP, mucin, vimentin, and S100. I found this large literature review looking at close to 1,600 patients with myxopapillary ependymomas. An interesting finding is that the conus can be involved in a large percentage of the patient, as we can see on the left lower slide, although it varies. Looking at the survival at 10 years with gross total resection or even subtotal resection, it's pretty high. It's almost close to 90%. Also, there's this JNS article that investigates the metastatic potential of myxopapillary ependymomas. They look at a series of 19 patients. Around 58% of the patients had metastasis. Interesting, only 36% of the patients had metastasis at presentation. And of those who had metastasis, around 45% of the patients, the metastases were located in the thoracic spine, as in our case.
Yeah, and I don't know if metastasis is the right word. It's like a multicentric tumor.
Okay.
It's not like it. I mean, in my opinion, in this case that is presenting benign, that it's not like starting as a small lesion and then all of a sudden, boom, it's all over the place.
Okay. Excellent. Okay, thank you. Okay, moving on. Case number 3. Let's do Damien. Damien, are you around?
Yep, I'm here.
Okay, perfect. So 28-year-old male with no past medical history who presents to the ER after a left hemibody tonic-clonic seizure, had been experienced no prior symptoms when he
How
experienced
you
it
doing, my love?
by his girlfriend. He was confused after, but remembers being brought to the hospital. So Damien, what other things you want to know about the history of this patient?
Has he had any seizures before? Or is this
Excellent.
first time seizure?
Yeah, so no prior seizures.
What was he doing anything in particular at the time? Prior to present the seizure, did the seizure have an aura?
Yeah, no, not really. No, not really. First seizure happened out of the blue. What about headaches? Will you ask about if the patient had any headaches or?
Sure. Yeah, headaches, any nausea, vomiting, changes in vision.
Exactly. So very good. So first time seizures, that's very important to know. If the patient had a history of seizures, then the differential it's going to be different. And then obviously if there's any associated symptoms, headaches, nausea, vomiting, as you ask, you want to know those things, to rule out any like increase in intracranial pressure as the cause of seizures. Very good. Here's the physical exam. Basically, this is a normal exam. What type of images will you want to have for this patient?
Definitely an MRI with the brain, with and without contrast.
Okay.
All right. On the left is T1, right is T2. Looks like somewhat cystic lesion in the right frontal lobe, fairly large. Does not appear significantly contrast enhancing on these images.
Okay, that's good. So how would you describe these images? As you were saying, multilobulated, solic and multicystic. There's some hemorrhage, intraaxial mass with some components that exhibit some enhancement localized in the right frontal lobe, basically. So will you want any additional imaging in this patient? Any other sequences that you want to know when looking at this lesion? Anything that will help you if you want to do surgery on the patient? Any other sequences?
You could get DTI given that it's in the white matter tracts.
Exactly. So functional MRI, DTI, basically to try to localize or I guess map eloquent areas so it can help you with planning surgery. Excellent. Very good. What's your differential?
I mean, like a glioma would be high up. I mean, he's young, so GBM would be maybe less likely, but still could happen. Given the frontal location, maybe like oligo,
Exactly.
something like anaplastic.
Anything else? Young patients with seizure, although all the less likely. Like
I'm not sure. Like a low-grade glioma too. I mean, I guess even a young guy.
Okay. So as you were mentioning, obviously astrocytoma top of the list, oligo, and less likely, although young patients with seizures, they can also have PXAs, DNETs, and gangliomas. But obviously top of the list is astrocytoma, oligo. Very good. So how would you treat this patient?
Given that he's young and first-time seizure, but otherwise intact, I think offering surgery would be the best, not only to get a diagnosis, but if it's a low grade, you can potentially cure him with resection.
Would you do this awake or just
yes.
What do you think?
Yeah, I think you could offer awake.
Exactly, because of what?
Frontal.
Because
the
as you were mentioning,
involvement.
Yeah, because
in the frontal lobe.
Exactly. So
monitor motor.
It looks like close to premotor. So you wanna do it awake and maybe use some direct electrical stimulation to like do language and motor mapping. Okay, Very good. Excellent. This is the post-op images. Let's go to pathology.
Okay, so this is one of the pictures that you're most likely gonna see when you take your board. So this is the characteristic fried egg appearance that basically when we use this term, we are implying a oligodendroglial differentiation. As common in oligodendrogliomas, you have thin capillaries between nests of cells with clear cytoplasm. Next slide, please. This is a higher magnification. You can see that the tumor cells here are kind of irregular. They have kind of angulation and irregularities of the nuclear contours, prominent nucleoli. So we have atypia and pleomorphism, and also we have mitosis. So we are already in the high grade category of tumors. Next slide. This is again, these are the tumor cells, and this is a very nice example of vascular proliferation. So this entire structure here used to be a vessel with single layer of endothelial cells. As you can see, the lumen is completely obliterated by significant proliferation of the endothelium. And also here you have a vague glomeruloid vascular proliferation. Glomeruloid vascular proliferation are almost pathognomonic of high-grade gliomas. Next slide, please. GFAP is positive, which tells us this is most likely a glial neoplasm, likely astrocytoma or oligo, but we know now that this is an oligo with high-grade features. Next slide. OLIC2, which is a transcription factor, and we use OLIC2 as a screening tool to distinguish between astrocytoma and oligodendroglioma, because we don't want to do FISH for 1p19q co-deletion on every single glioma. It becomes very expensive. So OLIC2 is a transcription factor that is expressed by, in oligodendroglial neoplasm, it is expressed in every single tumor cell. And the negative cells that you see here are the endothelial cells. While in astrocytoma, it'll be patchy. There'll be areas that are negative, areas that are positive. So this one is strongly suggestive in combination with the morphology of an oligodendroglioma. And next slide. As required by the WHO, oligos are supposed to be IDH1 mutant, and this is IDH1. It is clearly positive. And next slide. P53 has to be negative because P53 is not involved in the tumorigenesis of oligodendroglial. It is involved in the tumorigenesis of secondary glioblastomas. So here you see some scattered positive cells, but that's not enough to call it P53 mutant. So this is an example of anaplastic oligodendroglioma, and we did FISH, and indeed there is 1p19q co-deletion. So this is confirmed at the immunohistochemical and the molecular level.
Excellent, thank you. So in general, oligodendrogliomas, they comprise about 2 to 4% of primary brain tumors. The average age of presentation is 40 years. Ratio of male to female, is 3:2. They frequently present with seizures, about 50 to 80% of the cases. They can have CSF metastasis between 1 to 10%. There's calcification seen on 90% of the oligos on CTs. Mostly are found in the cortex and white matter tracts and the cerebral hemispheres. And the frontal lobe is the most common location in about more than 50% of the cases. Real quick in pathology, as we already mentioned, the tumors are typically monomorphic with round nuclei with a salt and pepper chromatin pattern. Due to the way they're processed, there's some artificial retraction of the cytoplasm, leading to the characteristic fried egg appearance of tumor cells. There's a dense network, as we saw, of fine branching capillaries referred as the chicken wire pattern. And they usually have IDH1 or IDH2 mutation and 1p19q co-deletion that are required for that diagnosis. They usually stain positive for IDH1, ATRX, and FAP. There are several ways to diagnose 1p19q correlation, and in order to avoid detection of false positive cases with just partial loss, the multiplex ligation dependent probe amplification method detects the loss of loci, or loci, I guess, loci in 19q and 1p. And there's an example here where they look for an 1p, they look for 15 loci, and in 19q, 8 loci. And this basically are the controls on the sides. So this is one of many ways where you can look for a full correlation and not just a partial correlation on oligos. Also, looking at the surveillance, epidemiology, and end result data from the National Cancer Institute, they look at the extent of resection and the survival for oligos. And as not surprised, gross total resection increases survival time in all cases, grade 2, and also on anaplastic oligos. Okay, last case. Let's do Eva. So 31-year-old male with no prior past medical history, with a 5-month history of numbness in his right foot. He denies any pain or weakness. He was diagnosed with a thoracic lesion and had an attempted removal that was unsuccessful. The biopsy results came back as hemangioblastoma. We'll talk a little bit about that surgery a little bit later. So Eva, are you around?
Yeah, I'm here.
Okay, so patient with numbness in his right foot and a thoracic lesion that came back as hemangioblastoma on a biopsy. So what other things you want to know?
Does he have a sensory level, like bowel or bladder issues?
Exactly, very good. Try to localize lesion. What other things you want to know because the patient has an hemangioblastoma?
If he was treated with radiation in the past, or if he has like family members with VHL.
Exactly. Very good. So basically, with these patients, you always want to send them to a ophthalmologist to have a ophthalmologic exam to rule out any retinal hemangioblastoma. Also, you want to ask if there's, like you said, any familial history of similar tumors to rule out VHL. And you want to know more specific about any dermatologic distribution or any early signs of myelopathy. Here's his exam. It's basically, he has a pretty good exam. Full strength, no pathologic reflexes. So what kind of images you want to have for the patient?
Get an MRI.
Okay.
Thoracic.
Okay, thoracic. Here's the first set of images.
Yeah. So.
Second.
These are on the same date.
Yeah, this is the same date.
So it looks like a contrast enhancing lesion, the lower part of the thoracic area. I can't see which level it is. It looks like it's it looks like it's intradural extramedullary.
Okay.
Based on what it looks like on the contrasted scan, and then on the T2. Oh, can you go back to the T2? Sorry. It looks like there's a cystic component surrounding the solid component.
Okay.
And there's a big and there's a big like cystic structure that extends, or there's a cyst that extends all the way up to the mid-thoracic area.
Okay. Fair. Okay. So this patient initially presented to an outside hospital. This is their images, and I guess it was Texas, and the surgeon there decided to do a biopsy of this lesion. the intra-op pathology came at hemangioblastoma. So the surgeon decided to stop the surgery, and then talked to the patient and said that this lesion was not amended for surgery, that it was unresectable, and that the patient should have radiosurgery. What do you think about that, Eva?
Um, I think usually you can resect these lesions.
Exactly. So the patient had a second opinion at MD Anderson, and they obviously told the patient that he was a candidate for surgery, that the patient should have this tumor taken out. And he eventually came here to us, and this is the images he had when he came to us to discuss surgery. And basically, it's as Ava discussed before, this enhancing lesion in the mid-thoracic spine, in the lower thoracic spine. You can see here the prior Lamy defect. So the only thing I'll say is that this lesion it's hard to say in just one slide, but this lesion is intradural intramedullary. Obviously, homogeneous enhancing with mass effect on the thoracic corridor. Any additional workup, Eva?
So I would get an MRI brain just to make sure he doesn't have any hemangiomas in his brain, as well as a CT abdomen to make sure he doesn't have clear cell or like pancreatic cystoadenocarcinoma or VO. I guess ophthalmology consult, like you were saying before, too.
Exactly. So basically, a full workup to rule out any tumors related to VHL and obviously neural axis also. Very good. What's your differential? I mean, I guess it's straightforward, but what about intradural intramedullary tumors?
So if it's intradural intramedullary tumors, you can have astrocytomas and then also ependymomas as well.
Exactly. So we already know that diagnosis in this patient, but also, the differential for intradural intramedullary includes astrocytoma, ependymoma, and less likely metastasis. Okay, very good. So how would you treat this patient?
I guess you can go back in through the prior laminectomy site, and then it looked like it was close to the dorsal aspect of the cord, and so you could go in through the midline where the dorsal columns meet, and then I guess go in and take it out from there.
Exactly. So posterior approach to try to resect the tumor. Obviously, no need for instrumentation, right? It's going to be thoracic, small Lamy. And for this kind of cases, you'll use intraoperative nerve monitoring, right? Okay.
Yes.
So that's basically what the patient had. Revision T10 to T12 Lamy and resection of the thoracic hemangioblastoma.
That's
Very good.
great, Roberto. Just a couple of comments. Any role for pre-op angioembolization, Roberto?
Yeah, I think so. I think that these tumors are usually very vascular. I guess it's hard in that level. You worry about Adamkowitz, but if there's any way to safely embolize any feeders, I think there's a role for it.
I mean, I'd be interested to see what my interventional neuroradiology colleagues or neurosurgeons say, but I mean, in general, for the smaller lesions, and this is maybe mid-size, there's often shared blood supply between the tumor and the cord. So in many cases, they're not able to embolize it, but maybe for the exception being some of the very large ones. So typically we don't do angio embo on them. And the only other thing is, and we'll talk about it maybe afterwards, is the frustrating thing is that, that's the one thing you're not supposed to do with these tumors is biopsy it, because you just get massive hemorrhage. The goal is to try to remove it en bloc, so to speak. And the other frustrating thing was the persistence of our community neurosurgeon to insist that the patient get radiation treatment as opposed to surgery. And I think you'll talk a little bit about the effects of radiation on these lesions.
Yeah. Thank you.
Okay, so at low magnification, as you guys mentioned, this is a very vascular tumor. And at this magnification, you get the impression that you're dealing with a vascular neoplasm rather than hemangioblastoma. Next slide, please. However, if you zoom on small microscopic foci that are usually embedded within large hemorrhage, you start to see these tumor cells with clear, slightly vacuolated cytoplasm, which are characteristic of hemangioblastoma. And the large cells are not malignant. This is what we call degenerative atypia, which is commonly seen in tumors that are very well vascularized. Next slide, please. This is a different area. In the center of the field, you have these 1 or 2 cells of degenerative atypia. The differential diagnosis here obviously is, given it's a clear cytoplasm, is a clear cell carcinoma. And on top of that, these patients, if they have VHL, they have particularly increased incidence of renal cell carcinoma. Next slide, please. Luckily now, with the discovery of inhibin, this is not a problem anymore. A few years ago, when I was a fellow, we used to struggle between hemangioblastoma and renal cell carcinoma because we didn't have a good immunostain. But now we have inhibin, which is positive in all hemangioblastomas and negative in all renal cell carcinoma. So this one is at least focally positive, and it makes the diagnosis along with the morphology. So this is hemangioblastoma WHO grade 1.
Okay, so real quick, hemangioblastoma, as we mentioned, benign, highly vascularized tumors. They comprise about 2 to 6% of all tumors within the spinal cord. About 80% of them occur as sporadic, and about 20 as part of von Hippel-Lindau disease. Clinical symptoms depends on the size and location of the spinal hemangioblastoma. And by removing the solid tumor, if there's a syrinx involved with it, it usually collapses. Pathologies, we already talked about: proliferation of capillaries with variable size, closely packed, thin wall vessels. They usually have large neoplastic stromal cells with pink to clear foamy cytoplasms with fine vacuoles containing lipid. And their nuclei are hyperchromatic, and the cyst wall has gliosis and resental fibers. They usually stain positive for NSE, reticulin, CD34, or VEGF. So talking about different treatment options, especially in this patient that was offered radiosurgery, we have this article from Neurosurgical Focus that look at 46 spinal hemangioblastomas in 28 patients that were treated with radiosurgery as an option. And surprisingly, on patients with sporadic or even VHL associated hemangioblastoma, that control rate in about 156 months was above 90%. They say it's safe. They had no long-term complications of this therapy. So they still argue that surgery should be the primary treatment for this disease, but they say if for patients with VHL they have multiple lesions or lesions that are not candidates for surgery, they argue that radiosurgery is the treatment that has its value, and it has a control rate about above 90% in long-term follow-up. So this is something to have in the back of the mind for some of these lesions. Yeah. Okay, I think that's it.
Thank you. So we have Dr. O'Phelan next. Is she on the line yet?
Yep, I'm here. Hello.
Okay. Well, we're happy to welcome you back again to your annual presentation.
So I'm Christy O'Phelan. I think most of you guys know me. I usually get to see your bright, shining morning faces when I do these, but I will live through it without it. I also asked one of our rock star second-year medical students to come and help with this presentation, and she's going to tell us a little bit about the work that she's been doing at the end of the presentation. So hopefully she is on, and if not, she will be on by then. But we'll have some data to show you that is pretty interesting, that's related to this. So I will talk to you guys today a little bit about the neurologic and sometimes neurosurgical complications or symptomatology that's associated with COVID-19. Everybody is painfully aware of COVID and its ramifications on the healthcare system. It's a reality that we're all living through. Our lives have all changed because of it. It's rapidly changing. And I will tell you that the data that I give you will be outdated and hopefully not all, but partially obsolete, probably in a couple of months. But I will do my best to give you an accurate snapshot of where we are right now and how, and specifically the neurologic and neurosurgical issues that are associated with it. I don't have any relevant disclosures. I will tell you this is a photo that was actually on the front page of the online CNN this summer. And I just thought it was perfect. It was classic Florida. Somebody dressed up as the Grim Reaper and went to South Beach to one of the lifeguard stands. So this is sort of how we feel often in the ICU during this pandemic. It's been quite difficult at times, as you are all aware. I will tell you that when I prepared this talk, I pulled literature really from the last 8 months. And it was really interesting because it's been different than a lot of other talks I've given. By the time I was looking at the literature that was published in the last 2 to 3 months, many of the data points that I had gotten from the initial papers were really not correct or just significantly incomplete. So it's just a very clear reminder that our understanding of this infection and this disease process is absolutely developing at a really rapid pace, definitely different than anything that I have encountered in my professional life and probably yours. Because we have it's very compelling to study it. Obviously, it's something that's affecting all of us. And so we really are putting a lot of effort and money and human resources into understanding this infection. So the rapidity with which we are gaining new knowledge is really impressive. And you'll see that as some of my slides, you'll see show kind of, where we were in March and then where we are in October, November. Okay, so we're going to talk a little bit about epidemiology, not terribly much, but a little bit. We'll discuss obviously COVID-19 and SARS-CoV-2. So the SARS-CoV-2 is the acronym used for the actual virus. And COVID-19 is the way that most people refer to the syndrome, the disease syndrome, the symptomatology, the constellation of clinical findings. So often you'll see them used interchangeably, and in papers will predominantly use one or the other usually, but that's the way that it breaks out. We'll talk about neurologic ramifications of this infection and neurologic symptoms. And when I say neurologic, I don't just mean neurologic, I mean neurosurgical too. So I'm trying to be inclusive here. Therapeutic options, which is unfortunately not tremendously many slides. I wish there were more. And then Evie is gonna help us and talk about some of the local projects that we're doing, which are very exciting. Okay. The other thing I'll say is that you know, sometimes I'll say something that it doesn't make sense, or maybe I'll make a mistake, or whatever. Please interrupt me. It's harder in this format to see your faces. But if I say something that you really want to clarify, I'm okay if you speak up and just ask the question, because somebody else probably has that same question. And we don't always have time at the end, and often those questions are really relevant and important. So I'm not at all bothered by that. Okay. So oh, the thing I did not take into account was our lovely pictures here. I'll try and move us over. All right. Neurologic symptoms of the coronavirus infection. So there's actually, coronaviruses are not new. You know, COVID is new, but coronavirus has been around for a long time. There's 7 of them that are known to infect humans. 4 of them produce predominantly seasonal, usually very mild or moderate upper respiratory tract infection. So if you went back in time a year and a half before all of this happened, in the upper respiratory viral panel that you would send whenever you did a bronchoscopy on a patient, there were multiple coronaviruses, and we never really paid much attention to those because they were coronaviruses that kind of we knew were around, and they affected people you know, during the fall and winter, and we knew that it was usually pretty well tolerated. And so that's why initially when COVID happened and people were getting coronavirus positives back on their bronchoscopy specimens, everybody was freaking out, but that's really not specific to SARS-CoV-2. There's 3 coronaviruses that can produce severe disease and often pandemics. SARS-CoV was active in 2002, and Middle Eastern respiratory syndrome, MERS, was in 2012, and that's MERS-CoV. And then now we've had COVID-19 with SARS-CoV-2. So 3 distinct coronaviruses that seem to behave differently than the 4 other ones that were that really produce more mild upper respiratory infections. So often, much of what we try to understand about COVID, especially in the early months, came from work that had been done in the previous 10 years, looking at SARS and MERS, to try to understand the behavior of these coronaviruses when they were more severe, when the infections that they produced are more severe. So there's the potential for direct viral infection into the nervous system, into the central nervous system, and as well as the peripheral nervous system. And we'll talk about some of the potential mechanisms for that. And then, you know, there's para-infectious complications. So usually they're immune mediated. Sometimes they can be inflammatory. The immune mediated ones, for example, when we think of para-infectious neurologic phenomenon, we think of things like PANDAS in children, which is a syndrome that happens often after strep infections, and you know, Guillain-Barré syndrome or ADEM. Those are para-infection phenomena that happen usually after a viral infection that incites the immune system to somehow respond badly to the patient's own nervous system. And then there's post-infectious immune-mediated, which is a little bit what I was talking about. But interesting thing in reading about this is sort of the involvement of the hypothalamic pituitary axis on that, and how that can, if you have direct invasion of the HPA structures, you can actually create a situation where the patient is immunosuppressed by a beta adrenergic mechanism. And that seems to be a relevant mechanism for some of the symptoms that happen after these infectious processes. Okay, so as I said, initially, a lot of what we knew came from estimation or from estimates that were extrapolated from other viruses. So if you look here at this table, which was published in September, these are the SARS case counts and the MERS case counts. So these are actual numbers, and then they were used to extrapolate what would happen with COVID. And this is, these are WHO numbers with worldwide. These are China case counts, and these are the United States case counts. So these are estimates that were based on data that we had in May. So they used the data that they had from SARS and MERS. They looked at where we were in May. They did some math, and then they made some projections about what the minimum case counts would be in the United States and in the UK here on the right side. So if you look over here, patients with CNS disease, the projections were that extrapolated from SARS, we were probably looking at about 500 in the United States, and from MERS, maybe about 3,000 in the United States. So not a insignificant number, but not overwhelming. So that's with CNS. With peripheral, again, we're looking at about 500 to 2,000 cases. And then total patients would be, 5,000 cases if you look at the numbers that were extrapolated from the MERS pandemic. Pandemic. So I think what we're seeing with COVID is probably a little bit higher than that. Nobody has the absolute numbers yet. There's mostly estimates. But, we knew that it was coming just based on the previous infections to study. So SARS-CoV-2 was first identified in Wuhan, China. You guys have heard this story on CNN or Fox News or whatever you watch. And it was first reported in China in December of last year. Seems like that was just yesterday. It's been kind of a blur. But by August of 2020, of this year, there were 18 million cases globally with almost 700,000 deaths. And then if you fast forward to when I made this slide, which was on the 17th of this month, there are 11 million cases just in the United States with 200, and I just read actually this morning, we have hit 250,000 deaths in the United States at this point in the pandemic. So the rapidity with which this problem is accelerating is really important, and it is impressive. And I think that, although many of the predictions that were made early on sounded like they were a little bit histrionic, that we really need to pay a lot of attention to this because the disease is not showing signs of slowing down at this point. There's a wide spectrum of signs and symptoms, as you guys have all heard. So many of them are very generic and not that different from other viral symptoms. Some of them are more specific. And it's often, the diagnostic sensitivity of these things is not great. The incubation period is, thought to be anywhere from probably close to 3 or 4 days to about 11 days. And so there's some variability there. And I think that the real problematic part of this disease, this COVID infection, is that there's a large quantity of virus that's produced in the upper respiratory tract during that incubation period, which means that latent spread is really, really, really common. So that's different than saying, that patients patients may develop symptoms later. It's not that they're always asymptomatic, they're pre-symptomatic. So the person, and that's how we're doing a lot of the contact tracing, is somebody gets sick and then we can go back 2 weeks and know where they've been and then trace their contacts, because there's such a huge incidence of latent spread, because the viral load in the upper respiratory tract is very significant during that incubation period. And that is a little bit different than some of the other viruses, and why this virus seems to spread aggressively, and it's pretty virulent in its spread, because the fact that a lot of that is happening before the patients become symptomatic. So early registries, and when I refer to early registries, I'm really looking at like spring of this year, you know, have reported that about 30-35% of patients infected with SARS-CoV-2 or who develop COVID are showing some type of neurologic symptoms. So it's pretty common, and we see that in patients. Even the ones that aren't that sick will have some type of complaint often. Probably headache is the most common, which is obviously not specific to COVID. I think headaches are very common in viral syndromes. Myalgias actually are also associated with that. I didn't include those. Encephalopathy, though, is quite common. Confusion and delirium. Patients say that they feel like they're in a fog. Often that doesn't clear even after the initial syndrome. And I think some of the data that Evie and her and Aham's group are looking at cognitive dysfunction post-COVID, and it's a very significant issue. One of the things that really struck me when we had our ICU occupied solely by COVID patients was the very, very significant encephalopathy and very tacoma, really, that these patients experience with this syndrome without any structural evidence of injury. Patients were absolutely encephalopathic and sometimes completely unresponsive with this infection. Neuropsychiatric disorders and psychoses are common. The dementia, I think, is mostly people are referring to a more prolonged or chronic and less fluctuating encephalopathy. And then affective disorders are also common. I'm sure that in the coming months to years, we will have more accurate data as to some of the psychiatric disorders, including PTSD and such, that are often seen after this type of infection. And then there's more specific neurologic problems that come up either because of cerebrovascular events, acute ischemic stroke, intracranial hemorrhage, and CNS vasculitis have all been reported, not infrequently. Some of them are complications of treatments, and some of them are due to an underlying hypercoagulability that has definitely been noted. Acute necrotizing encephalopathy, which we believe is cytokine mediated, has been reported as well, and we'll see some pictures and talk a little bit about that. Epilepsy, and seizures are not uncommon. They're not always convulsive, so sometimes in these patients that are unresponsive, it's really important to look for subclinical or non-convulsive seizures, as well as ataxia as a sequela after the infection. Okay, so when we talk about these syndromes, it's important to think about what definitions are being used. So the WHO has tried to give us a framework to work within. I think this is important when you're reading everybody's trying to keep up to date on this infection because it impacts us all. And so confirmed by WHO guidelines means that there's laboratory confirmation. So that means either a PCR showing viral genes or gene products of SARS-CoV-2, or an antibody test that's positive. So those are confirmed cases of COVID. Probable cases are when testing is inconclusive or could not be done. So if you think about the WHO, they're also covering places that have low resources and really don't have the ability to test people. They're going on clinical scenarios and on community evidence of community spread of this disease. And so when they say probable, it doesn't necessarily mean that that testing was negative. It just means that often that the testing couldn't be done. And then suspected is, again, a way to address when the testing is not available. You have a respiratory illness with fever, and you have known community transmission within the past 14 days, or even severe respiratory illness in the absence of an alternative explanation. And so this is an effort to try to collect accurate or meaningful data from areas of the world that really do not have the ability to provide widespread testing as we do in this country and Europe. Okay, so there are several neurologic manifestations of this infection: meningitis, encephalitis, myelitis, vasculitis. We'll talk about some of these. When these are thought to be confirmed related to COVID, that means that there's brain tissue or CSF with actual virus found, or intrathecal antibody, which means CSF, and the absence of another explanatory pathogen. So that's really rare, I'll tell you. There initially, for the first 3 or 4 months of reports, there was really no evidence that the virus was found inside the CNS. More recently, it has been identified in the CNS and in the CSF, but it's really very rare. It's like 2% or something. It's really small number. And we can talk a little bit about why that might be. So, absolute confirmation, I think, is quite difficult. Probable is more common, and that is when you find the PCR positivity or the antibody in respiratory, i.e. non-CNS samples, and no other explanatory pathogen. And this is really where most of our data sit at this point. You have patients that test positive within the respiratory tract. They're clearly sick. They clearly have COVID, and then they develop meningitis or encephalitis or vasculitis. And that's really what most of our patients look like that have neurologic ramifications of this disorder. And then there's possible, which means it meets the suspected case definition of myelitis, let's say, and then the clinical syndromes and epidemiologic factors fit. And then you can also have radiologic findings that are suggestive. And that does not require actual COVID testing positive. And again, these are WHO guidelines, and so they are taking into account places that do not have the ability to do widespread testing. Okay, so this is an example from a recent publication of what acute necrotizing encephalitis will look like. You can see the MRI images here. The flare changes that you see in panel C are bilateral thalamic, which is a pretty distinct distribution. I think if you saw imaging that looked like this, your differential diagnosis, might be something like a systemic insult, like anoxic injury, carbon monoxide poisoning, or ADEM is, sometimes in this distribution. If you look at panel B, which is an SWI or a GR, I think it's an SWI sequence, you'll see that there's definitely some hemorrhagic component to these lesions, and that makes this distinct from typical acute disseminating encephalomyelitis or ADEM. And it has been reported and documented multiple times in COVID. And so there seems to be a necrotizing component to the diffuse inflammatory response. ADEM is known to be often post-viral, and it is thought to be mediated by an immune response that is too high and causing abnormalities in the brain. And the distribution along white matter tracts is really very typical. So you can see these areas here. You can see it here in the cerebellum, and then in DWI it will be bright. So over here there's DWI. If you look at panel D, they do not necessarily enhance. So this is a non-enhancing pattern to this lesion, which is I think quite typical. And I think the problem comes with, well, how do you treat this? And we can look at some different options. I don't think anybody has good, high quality data about efficacy for any therapeutics at this point, but we have sort of an armamentarium that we usually will use for other immune mediated neurologic insults like ADEM. And that's for the most part what's being used in these situations. So again, for ADEM, Guillain-Barré syndrome, and acute neuropathies, probable will mean that the symptomatology comes is seen within 6 weeks, usually 4 to 6 weeks of the known COVID or SARS-CoV-2 infection. These are known to be immune-mediated post-infectious disease processes. And there can be RNA or antibody evidence of acute infection, not necessarily in the CNS, but just in the patient. Usually it's respiratory, and no other commonly associated causes. So for example, Campylobacter or such with GBS. So I think that, again, sometimes it's a process of exclusion, and you have to make your best bet. In the end, it probably doesn't matter because you're going to be treating the acute infection with antivirals, and you're going to be treating the acute inflammatory or immune-mediated process with immunomodulation. And so the therapy is probably not going to be different. But for purposes of trying to document the effects of this pandemic, it is important. Possible means that you're within 6 weeks of your COVID infection, and you have some other commonly associated cause found, but you also have evidence of a COVID infection. And so in those cases, they're being listed as possible. So this is an example of ADEM, which happened after a COVID infection. I think that it is, when I was looking at this image, I was like, well, okay, yes, it is ADEM in that it's white matter, it's diffuse. I think that you could make a very good argument for looking at panel D and saying, particularly in the right hemisphere, are these ischemic watershed lesions? There's sometimes some DWI positivity. The distribution is kind of, it looks like that watershed. On the left side and the left hemisphere, they're a little more confluent. So much of what we do is find the symptoms, which would be acute onset of a sort of diffuse process in encephalopathy. There may be motor components depending on where these lesions are. but then also looking at the patient's overall clinical picture. In the case of ADEM, it will be really important to get CSF because you want to see that there's an active immune-mediated problem that's happening intrathecally, right? And that will distinguish this from ischemia, for example. So it's important to know that it's not just based on radiology. It's definitely the clinical syndrome, the patient's history, the fact that, I mean, just because they had COVID doesn't necessarily mean that they have to have ADEM. They may have ischemic strokes because we know that these patients are hypercoagulable. And so it's important to do the workup and to do an LP and to send, you know, inflammatory markers, IgG index, for example, will be very helpful to be able to show that there's an intrathecal immune response happening in these patients. And this is actually quite clinically relevant, right? Because if this patient has a vascular problem and ischemia, the treatment may not be the same, you know, wouldn't be the same. If they have ADEM, you're really going to be looking at immune modulating therapies like IVIG and PLEX, which are going to be used to try to modulate the immune response. But this is an example of what it was recently published in the Journal of Neurology as a ADEM post-COVID. And you know, they did the appropriate workup, and I'm not arguing with their diagnosis. I'm just saying that based solely on the imaging, you probably wouldn't be able to say that 100%. So what about the peripheral nervous system? We always tend to forget about the dear peripheral nervous system. So probably Guillain-Barré is the most commonly reported. Actually, that's not true. It has been commonly reported, but it's probably not the most commonly reported syndrome after COVID and SARS-CoV-2. AIDP is sort of the more generic way of referring to acute inflammatory disseminated polyneuropathy, which is Guillain-Barré syndrome. There are many different flavors of AIDP, and they have, as this pandemic goes on, different types have been identified. So Miller-Fisher is an AIDP that starts predominantly in the cranial nerves and then goes down, as opposed to starting peripherally and working its way up. AMAN is a motor neuropathy, which has specific serologic markers for the type of peripheral neuropathy. The distinction to some degree is academic. It's important to be able to identify the different symptomatology so that people can diagnose and treat this AIDP. But in the end, the treatment is really the same, which is what you would do for Guillain-Barré syndrome generally, which would be IVIG or plasma exchange therapy to provide immunomodulation for these patients. So anosmia and changes in taste are what has been broadly publicized in COVID-19 as an important symptom. It's very common in viral illnesses. So it's common in other coronavirus infections as well as influenza. So it's really not specific at all to COVID. I think that the anosmia that comes with COVID in the majority of patients is very severe and rapid, and people notice it. And so I think as this syndrome unfolded, people were very aware of it. I know many ICU nurses that and intensivists that every morning we would get up and like smell something, either bad or good, just to make sure we were okay for the day. And I think probably people are doing that still. And it's probably not a bad idea, because often the anosmia will be one of the first things that people notice. It can occur in otherwise asymptomatic patients, or be an isolated presenting symptom. So you may develop the anosmia before you develop the respiratory syndrome. So it is important because it may be a way for people to know to get tested earlier. And it is thought to be a predominantly peripheral nerve phenomenon, with the olfactory nerves being affected as the virus will enter through the nasal passages in the upper respiratory tract, that it seems to be a peripheral nerve involvement that causes that anosmia. There have been some reports of encephalitis-like picture or imaging changes in the gyrus, the olfactory gyrus in the inferior frontal lobe after this. And so it may be that the virus is able to enter the brain via the olfactory nerves and then cause central infection and invasion. I think there's a lot of research kind of looking at that to see if that's a true mechanism. But I think in general, the anosmia is probably the most common peripheral nervous system symptom that we're seeing with COVID.
Hey, Christy, I was going to
Yeah.
interrupt you for a second, as
Sure.
you had indicated at the beginning of the lecture. No, I really find that this is fascinating regarding the anosmia, and it seems to be very specific, like you said, and it's as opposed to some of the other illnesses that you were describing, which are happening in very sick ICU patients, day 28, day 59, in the ICU, which may be related to their multi-system problems, but this is early, specific, and I think like you said, that there's been some research to suggest that it's an infection of the support cells of the olfactory neurons as opposed to the neurons themselves, because most people actually do recover. Although it can take a long time, and if it was neuron or neuronal death, that they may not. It is, and it's independent of like mucosal, inflammation and things like that.
Yeah, absolutely. It's interesting. I have a couple of slides looking at the receptors that have been identified, and sort of, I think there's a lot of really active research looking at how neuroinvasion might work and which cells are actually involved. And it's fascinating. I think that this is, rapidly evolving. And I don't know, maybe it will have implications for therapies, down the line for sure. Okay, so CNS disturbances, as I mentioned, encephalopathy is very common. Many of the encephalopathies are probably toxic metabolic, as we see in ICU patients in general. But some of them may be more directly related to the viral infection. Encephalitis obviously will be either immune mediated or direct invasion of the virus. Like we see that with herpes virus, not uncommonly. I think it's still on the table whether or not the SARS-CoV-2 virus has direct invasion commonly. I think we know that it's not common, but it can happen. I think it's fairly rare. And then seizures and then vascular disorders, as we mentioned, are also obviously seen pretty commonly in the CNS disturbances. So again, I'm going to move us so that you guys can see what I'm talking about here. So direct invasion can happen. This little picture is actually of the respiratory tract, but it is a good way of showing the way that these receptors work. So if you looked at the papers that were published in the spring, the two receptors that seem to be important for entrance of the virus into the airway and then and probably into the brain are the angiotensin converting enzyme 2 ACE2 protein and the transmembrane protein serine 2 TMPRSS2 protein, which is important for processing. And these were the two that were kind of found first. There's more, but if you look, this is a picture of the airway and epithelium. These little Y-shaped receptors are the ACE2 receptors, which are important for the coronavirus to dock. And that's what this picture is the coronavirus there docking onto the ACE2 receptor. And then over here, this little lollipop looking one is the transmembrane protein, the receptor that is important for processing. So these act together, and then this coronavirus is able to enter the cell and then cause problems. This is pyroptosis. So this cell goes through pyroptosis and will then set off the immune cascade, as well as viral DNA being put into the patient's system. And this is thought to happen not only in the respiratory tract, but also in the brain. Although there's minimal expression in a healthy brain of these two receptors, there has been evidence now that there is expression of these receptors inside the nervous system for sure. There's experimental data that shows that if SARS-CoV-2 does invade the nervous system, that it can cause neuronal cell death. And I think that's one of the things that Dr. Levy was referring to. Probably doesn't happen that often because the anosmia does recover. The encephalitis, I think also many of those patients can recover. So I think it doesn't always cause neuronal cell death, but it probably is affecting the neurons in the minority of cases. Let's see. Parainfectious, we talked about GBS and transverse myelitis, and that would also affect the central nervous system. So I'm going to move us back over here so you can see this cool slide. So this is from Cell. You know, I don't get a chance to read Cell that often, but this is October volume of Cell, and this is super cool because this is basically an example of all the different genes that are being found to be expressed in different areas of the nervous system that are now known to have to do with viral entry or viral defense. So you'll see over here, these are the genes that are involved in viral defense. These are the docking and processing genes for viral entry. And then these are the locations within the nervous system. So vascular, glia, and then the bottom two are neurons. Well, as you can see, it's pretty sparse down here. Neuronal expression is not really where the money is. It really looks like the vascular, endothelium, and pericytes are really where a lot of this action is happening. So I think these data, obviously, if you look at the papers that were published in March, this was not known. If you look at October, clearly now we have a much better vision of where this virus is able to enter the nervous system. And I think this could be really important for trying to understand the pathology, but also how to maybe prevent this from happening. And you know, the ACE2 and the serine receptors that I was telling you about before are here, but really they're not actually the biggest players. You know, you've got these other ones that are turning out to be probably more important. Okay, so routes of entry, importantly, there's a lot of potential mechanisms. People don't know this for sure. There's little direct evidence. The olfactory route is obviously seems compelling. The blood-brain barrier theory, you know, you can find figures sort of looking at the theoretical mechanisms. I don't think we have the ability to say for sure, but many of the cytokines that are released with this viral infection will break down the blood-brain barrier and allow for viral entry that way. And then infiltration of infected immune cells. There's a lot of work on this. The virus can enter macrophages specifically, and then be carried into the central nervous system via macrophages, and then infect the CNS in that way. And I guess the PNS too. I read a lot about the CNS, but I don't think it's specific to the central nervous system, actually. This is a figure from the Lancet that actually looks at the time course of the different clinical presentations with COVID. So this is the time of respiratory symptoms, day 0. And you can see the RNA, IgM, and IgG as they become positive. This is 14 days here. So IgG, is positive by probably by 7 and definitely by 14 days. You see the expression of myelitis and encephalitis kind of earlier on, and then ADEM and the other post-infectious type phenomenon can go out, like we said, 4 to 6 weeks out here. I don't know how well this projects, but the light colors do go out here to 6 weeks post-infection. And so this is sort of the algorithm that we're using to try to understand some of these phenomena. This is another image that was published to demonstrate some of the typical CNS problems that happen with COVID. So this is an image of encephalitis. This, you can see flare changes in the medial temporal lobe here and here. On coronal view, this is pretty typical of any viral encephalitis. We see it most commonly with herpes, but you can see it with really any viral encephalitis. And COVID-19 is no different. We talked about the necrotizing encephalopathy earlier. Again, central here, these thalamic lesions with SWI changes on centrally indicating necrosis. And then we see quite a bit of vascular problems, ischemic stroke being one because of the hypercoagulable state. So some of these changes are inflammatory. I'm going to talk a little bit about the multisystem inflammatory syndrome that is being found predominantly in children and adolescents. We are tracking the inflammatory processes with biomarkers. We use D-dimers, we use IL-6, and we can do that during the inpatient hospital stay to try to understand the inflammation component of the patient's disease. Cytokine storms are something that can be treated with specific regulation of cytokines like tocilizumab and anakinra. So we have a kid that's in the unit, somehow still alive right now on West Wing 8. He's 19-year-old, came in with TBI over a month ago now. This was his initial head CT. Per his mom, he was actually walking and got hit as a pedestrian, I think. And it's not super exciting CT there. He has cephalohematoma. He's got kind of a tight looking brain, but he's 19. There were some frontal contusions you can see over here, but nothing surgical. He got an EVD. He was in our ICU. He had some elevated ICPs. His initial PCR was negative. There was nothing in the history. We don't get a very broad and thorough history often with these trauma patients, but his PCR was negative and we went on with our lives. He developed pneumonia, which is pretty common in patients with TBI, but it's, as you can see, it's a pretty severe bibasilar pneumonia. And it looks maybe a little more peripheral than usually our lobar pneumonias, but we didn't really think much of it. We treated him the usual way. He got some bronchoscopies, he got some antibiotics. Then he developed these really pretty significant DVTs. So this is his right femoral vein, and with compression, it doesn't change at all, which means that it's full of clot. And actually he had clot that went from the external iliac all the way down through the common femoral. And it was a very, very long, large, occlusive clot, ended up with a lot of edema through that whole limb. And then unfortunately, this is kind of what's happened to his lungs. His lungs, his lungs have just disintegrated. So I know you guys aren't used to looking at lungs that often, but these lungs look horrible. So this is a pneumothorax over here. He has a bronchopleural fistula. It formed by rupture of one of these blebs. These are blebs that happen. And I will tell you, this kid had a normal chest CT when he was admitted. And this is what his chest CT looked like 30 days later. His lungs are like Swiss cheese. to the point where pulmonary thinks that he's, he may need a lung transplant if he survives this. And this was with a negative PCR. Well, when we did antibody testing, the antibodies were positive. So this is a post-infectious phenomenon. This is related, in our opinion, this is related to COVID, but it's not an acute infection, it's a post-infectious. And that is thought to be one of these, oops, I have to drag us over. One of these syndromes that is being recognized predominantly in children and adolescents. It's referred to as multisystem inflammatory syndrome, MISC, or PIMS-TS, pediatric inflammatory multisystem syndrome, temporally associated with COVID. I like MISC, but it's the same thing. It basically is found in children and adolescents predominantly. This kid was 19. It develops after COVID, and it can present in the pediatric literature, they say like Kawasaki's disease, but we don't see a lot of Kawasaki's disease. So I'll just tell you, Kawasaki's disease is the leading cause of acquired cardiac dysfunction in children. It's post-infectious, immune-mediated. It causes shock, and it can also cause a vasculitis syndrome and multi-organ failure. In this case, we think that there's a very significant inflammatory component in the respiratory system. If you look at, this is a table looking at MISC and PIMS. And if you look at the main features, neurologic disorders are featured in both of these. So it's pretty common to have some sort of neurologic problem, whether it's an encephalopathy, whether it's seizures, whether it's an encephalitis, or a peripheral nerve problem. Those are all potential immune-mediated complications. But this is something that we probably will see more and more, and maybe in the pediatric population will become more important. Okay, this is again with characteristics of MISC. This is 50% of the patients that have been reported so far will have some neurologic symptoms. I'm going to go a little fast so that Evie has time to talk about her slides. Okay, the therapy is unclear. Steroids are used because everybody loves steroids, and they are immune modulating. They seem to be helpful in COVID, and so people are using them. It can be either dexamethasone or solumedrol. People have used IVIG plus or minus aspirin, as well as more direct cytokine inhibitors like tocilizumab or anakinra. There's quite a bit of hematologic complications that are associated with COVID. There's been a lot of reported thromboembolic complications, PE, DVT, MI, acute ischemic strokes. When these patients end up on CRRT or ECMO, their circuits get clotted really, really commonly. But interestingly, when you take out immune-mediated clotting or clotting associated with catheters, it sometimes has been reported to be quite low. So the thought is that it's not typical thromboembolic disease with DVTs going to PEs. A lot of times it's more immunothrombosis, which may mean that the inflammatory process is somehow very important in the development of these complications, and that it's more thrombi rather than emboli, which is important for treatment. So these patients may do better with immune modulation rather than just anticoagulation. There are changes in the coagulation proteins. Fibrinogen, von Willebrand factor, and factor VIII have all been changed after COVID. And we do know that there is activation of coagulation, and many of these patients are getting anticoagulated as a standard of care. There's also a possibility for endothelial infection of the virus directly, which probably has an effect on a procoagulant presentation and loss of protective antithrombotic activity. So early reports show that the patients who are anticoagulated tend to live more commonly. And so many people are providing anticoagulation. What we don't know exactly is what the right dose is. There's definitely been documented bleeding risk, and in some small series, up to 21% of patients, most of whom are anticoagulated, will have major hemorrhage, which either means hemorrhage in their brain or a massive GI hemorrhage. Many of those patients are on full dose or sometimes super therapeutic doses of anticoagulation. So I think we don't really know what the right dose is. And many people are using sort of an intermediate dosing regimen. No, the therapeutic dose of enoxaparin is usually 1 milligram per kilo BID. So people are kind of going to this 0.5 mg per kg BID. And there will hopefully be some prospective data that's randomized to help us understand the efficacy and the complication rate for this. So the logistical challenges obviously are that we have very large numbers globally paired with limited evidence to guide therapeutics. And so basically the therapeutic options that we're left with are vaccinations, which I'm hopeful will actually be available hopefully by next year to us. We unfortunately are not that good at vaccinating large numbers of adults, but maybe this will be the time for us to learn how to get good at that. Antiviral agents are used, and managing the inflammation and organ failure and thromboembolic complications are important. This is our protocol. I can send it to anybody who's interested. This is at Jackson. Basically, it is remdesivir for moderate to severe disease, no hydrochloroquine, no ivermectin, and yes, for tocilizumab for moderate and severe patients. There's very clear criteria. They have a very extensive document that is updated every few months. If anybody is interested in this, and you don't have it, I'm happy to provide it so that you can look at the details of this. There are a couple of trials that are available to our patients, Rimdacta as well as aviptadil. One's a synthetic human vasoactive polypeptide. The other one is remdesivir plus or minus tocilizumab. It's important to collect prospective data so that we have better ability to decide treatments. This is unfortunately from the CDC yesterday, so you can see what the number of cases in the United States looks like. This is not a happy slide, and it is what is happening right now in our country, so this is important. And then these are the Miami-Dade cases yesterday. So, sorry, not Miami-Dade, Florida cases. So almost 900,000 with 52,000 hospitalizations and 17,000 deaths. All right, Evie, I'm sorry. Are you on here?
Yeah, I am.
Yes. All right. I'm sorry. You have like 5 minutes, but I know you can do it.
I'll be good. Well, thank you, Dr. O'Fallon. I'm Evie. I'm the second-year med student. So I do research with IAM on neurological complications and specifically now during COVID. So overall, our population, we collected on COVID positive hospital admissions between March 31st and October 16th of this year. And overall, there's 415 hospitalized patients. We currently have completed a chart review on 225 of these patients. And from this population, about 84% or 189 of the patients were presenting with or developed neurological complications. So from the discharge, 333 survived hospital discharge. And from that group, what we're doing is we're doing 3-month follow-up by phone, of which we've completed 29 of them. So looking at the population we've collected so far, we wanted to focus on the neurological complications. And most specifically, we've had common ones like headaches, dizziness, delirium, which we defined by the DSM-5 criteria, which includes confusion, agitation, disorientation. And in addition, we've had some more unique complications like stroke, seizure-like activity. And in addition, as we talked about earlier, we've seen about 25 reports of metabolic encephalopathy as seen on like imaging. So if you could go to the next. So some of the select complications and cases we've seen. So looking at first, we have a 68-year-old man with past medical history, significant for COPD and hypertension. His hospitalization was complicated by multi-organ failure. And during his ICU stay, he developed necrotizing leukoencephalopathy, which can be seen here on the DWI imaging. There's multiple areas with diffusion restriction demonstrating the cytotoxic edema characteristic of this necrotizing leukoencephalitis. So if you go next, our second case we have is a 70-year-old man with past medical history significant for coronary artery disease. And during his hospital stay, he developed ARDS and septic shock. He was actually transferred to the ICU where he experienced a right temporal occipital lobe infarct with a PCA distribution with some hemorrhagic conversion. Sadly, he was not a candidate for revascularization therapy, and he later passed due to a PEA arrest. So that's our two really cool cases we've seen of some of the neurological outcomes. But going forward, as I said, we're doing some 3-month follow-ups on all the patients who survived hospital discharge. We're doing them by phone and looking at really 3 main domains. One being their neurological outcomes, their motor outcomes, and more of their psychological outcomes. So far we've completed about 29 of these. 4 patients were actually deceased by the time we called them. So first looking at our neurological outcomes. So 8 patients expressed having cognitive impairment, which was defined as any issues with memory, concentration, processing speed, or language. We also saw some more of the common outcomes like having weakness or fatigue and headaches post-hospitalization. And next, we did some motor impairment. So looking at motor impairment, we used the Barthel Index for activities of daily living, which includes domains like feeding, bathing, mobility, dressing. And from these scores, there's a really positive skew with a majority of the patients not really experiencing significant motor deficits. And when conducting these interviews, which I do, a lot of them expressed that early on post-discharge, they had some weakness, they used walkers, had difficulty walking, but overall in 3 months, they had a lot of signs of recovery, which is very positive to see. And lastly, looking at some of the psychological impairment, something I'm very interested in is looking at post-traumatic stress syndrome from hospitalization due to significant diseases like COVID. So in order to do this, we use the PCL5, which is a 20-question DSM screening tool for PTSD. And overall, if you could go to the next slide. So with the 20 questions, while it's important to look at overall scores and having these cutoffs for diagnosing someone with the syndrome, I think it's also cool to look at specific variables and specific questions where people were scoring the highest, having the most distress with. So here for question 7, this is one that they scored very high on, sort of avoiding external reminders of having COVID and their hospitalization, which is very interesting to see. And on the next page, we also have these 2 questions. People are having a lot of difficulty concentrating and troubles falling and staying asleep, which I find interesting. So overall, while in those 3 questions, people were scoring very high on, overall 6 people actually self-reported having some psychological impairment, which can include anything from anxiety, distress, or depression. And 3 patients so far have screened positive for this post-traumatic stress syndrome. So we're gonna go forward, keep collecting and also doing these phone follow-ups. And of course, thank you to Iam. He's the best mentor ever and lets me do cool things like this.
All right, Evie, that was amazing. You did it in 6 minutes. You are a rock star. So Aham and Evie have done a lot, and Daniel's actually on here too. Daniel is our coordinator extraordinaire and helps all of our clinical research happen. And I think that doing this type of work is really important at centers like ours, and we can really help move the needle forward. To try to understand more about this disease and syndrome. And this is a picture from the unit of all of us in our war paraphernalia, which unfortunately I think we still need to keep a hold of. So thank you for your attention. I'm happy to answer questions if you guys have any. I know we're a little bit past the hour.
I had one question. For the Guillain-Barré and Miller-Fisher type phenomenon you're seeing, are those mostly post-COVID or are they in the acute phase? Because we had one kid that we thought might be.
Yeah, I mean, I think by the guidelines, they require within 6 weeks. So, but I think we're not seeing it really before 2 weeks. So probably in that 2 to 6 week time frame.
But I presume some of them may test negative on their COVID test, but have these interesting phenomena.
Correct. Just like our TBI patient, right? So your initial PCR will be negative, but your antibodies will be positive.
Okay.
Yeah. Chirp, chirp. Okay, I don't hear any questions. If anybody wants any of the references that I used for this, I have them. I'm happy to give them to you. Hopefully we won't end up with a COVID unit on West Wing 8 again. Thank you for your attention. Bye-bye.